Let me just introduce you Ángel Martín Montes, which is our today's speaker. Ángel is a neurologist at the Cognitive and Behavioral Disorders Unit of La Paz University Hospital. He's a graduate from the Complutense University, and he has developed all his professional activity at the La Paz Hospital, where he finished his specialized training in neurology in 2014. And after that, he has developed a specific training in the area of neurodegenerative diseases. He has participated in a number of clinical trials related to Alzheimer's disease as a sub-investigator. And lately, he has been also trained in dementia at the Memory and Aging Center at the UCSF and the direction of Bruce Miller. During this time, he has been able to participate in different clinical and translational research projects as part of the neuroscience research group of the EDPAS Research Institute. He also has carried out several projects in collaboration with other groups, such as that of María Jesús Bullido at the Molecular Biology Center in Canto Blanco. And he is currently a member of the Behavior and Dementia Study Group of the Spanish Society of Neurology, and is pursuing a doctorate at the Autonomous University of Madrid. So I would like to thank Ángel for his willingness to share with us his work today. The title of his presentation is Cholesterol in Peripheral Leukocytes of Patients with Alzheimer's Disease. So Ángel, welcome, and thank you again. And please go ahead. You can share your presentation now. And
Okay, thank you very much for the presentation. I don't know if I will share my screen. Well, good afternoon. First of all, I would like to thank CIBERNED for organizing these webinars that allow to share research studies from different groups and thus favor the communication of results and updates on various aspects of neurodegenerative disease. I will talk about cholesterol in peripheral leukocytes of patients with Alzheimer's disease, a project in which I have been able to participate in the past 5 years thanks to the collaboration between those of us who work in the clinical part of the disease at University Hospital La Paz and the team of María Jesús Bullido from the Molecular Biology Center Severo Ochoa, who have carried out the laboratory part and helping me in the analysis of the data. Well, and the first question that should be asked is why investigate cholesterol metabolism in neurological disease? The brain contains approximately 25 to 30% of all cholesterol present in the human body. Most of this cholesterol is found in the myelin sheaths that cover the axon of the white matter, and the rest is located in neurons, astrocytes, microglia, and lipoproteins. Apolipoprotein E is the main protein in charge of transporting cholesterol in the brain under physiological conditions, not finding levels of other lipoproteins such as LDL or VLDL that under normal conditions do not cross the blood-brain barrier. Well, for this reason, most of the brain cholesterol is derived from new synthesis in the endoplasmic reticulum of neurons. Small amounts of cholesterol can also come from the peripheral blood through a high-density lipoprotein, unlike LDL and VLDL, which do not cross the blood-brain barrier. The enzyme hydroxymethylglutaryl coenzyme A is the rate-limiting step in cholesterol biosynthesis, with excess cholesterol converted to cholesterol esters by the enzyme acyl-CoA cholesterol transferase. At this level, some polymorphisms of the HMGCR gene are associated with sporadic disease, and studies in cell lines have shown that silencing the HMGCR gene decreases oxidative stress, induced apoptosis in neural cells. On the other hand, increasing the level levels of cholesterol ester increases the concentration of amyloid beta in cell cultures and inhibiting ACAT, a reduction of cholesterol esters and amyloid beta is observed. Cholesterol is also involved in beta amyloid clearance in several ways. On the one hand, through ApoE, released mainly by astrocytes, apolipoprotein E particles released by astrocytes that bind to cholesterol can mediate beta amyloid proteolysis through its internalization and clearance through the lysosomal pathway by binding to LRP1 receptor. On the other hand, cholesterol-bound ApoE can clear amyloid as well by a complex between ApoE and beta peptides that is able to cross blood-brain barrier and be released in the bloodstream for its elimination. Another protein implicated directly in amyloid clearance is ABCA1. This protein controls intracellular cholesterol levels and modulates ApoE lipidation by releasing intracellular cholesterol into the extracellular medium, where it is taken up by ApoE. Studies in cell culture medium in cell cultures have shown that increasing ABCA1 levels, it is obtaining low levels of A-beta in the culture medium, and in animal models, by causing the deletion of the ABCA1 gene, the levels of ApoE bound to lipids decrease and the levels of ApoE increase the beta amyloid deposits. Well, cholesterol has been linked to Alzheimer's disease on multiple levels. On the one hand, regarding brain cholesterol, we know that ApoE is a main risk factor for sporadic Alzheimer's disease. On the other hand, the llevados studies indicate that the main polymorphisms that increase the risk of sporadic Alzheimer's disease are related to cholesterol metabolism. Other studies, as we will see later, have observed that the cholesterol content in cell and lysosomal membranes is related to the processing of APP in the so-called lipid rafts. On the other hand, circulating cholesterol has also been related to the disease. Most studies suggest that hypercholesterolemia would be epidemiologically related to an increased risk of Alzheimer's disease, perhaps mediated by increased cerebrovascular risk. On the other hand, the levels of 24-hydroxycholesterol in plasma and cerebrospinal fluid have been proposed as a marker of neurodegenerative disease. We also found studies that indicate that the cholesterol content of peripheral cell membranes could be altered in Alzheimer's disease. Well, one of the reasons that supports the involvement of cholesterol metabolism in Alzheimer's disease is that a large part of the polymorphisms described by genomic association analysis as risk factor for the development of the disease are related to the clearance of A-beta mediated by apolipoproteins. In the table of the slide, we can see the main polymorphisms described, and in red, those related to cholesterol metabolism, such as ApoE, CLU, PCAN, or ABCA. As we can see in the figure, cholesterol is mediated clearance A-beta about multiple of these mechanisms and multiple of these polymorphisms. Another reason that supports the role of cholesterol in the disease is the processing of APP in the cell membrane and in the lysosomal system. For years, it has been known that APP is processed through the amyloidogenic pathway, mainly in areas of the membrane enriched in cholesterol, called lipid rafts. The increase of these zones, or in the cholesterol content in the membranes of the lysosomal, led to an aberrant degradation of the amyloid peptide. The content of cholesterol and other lipids in the cell has been related to the appearance of neurodegeneration markers in multiple studies in cellular models, such as that we can see in the slide of Hui et al., in which an increase of content of LDL cholesterol in endolysosomes is related with the occurrence of Alzheimer's pathology in neural cultures. In this study, Philippine fluorescence was used as a marker of intracellular cholesterol. There are also studies in the cell outside the nervous system, such as fibroblast culture, in patients with Alzheimer's disease, in which were also observed alteration in cholesterol metabolism, such we can see in this study of Pani et al. Performed in a culture of fibroblasts for Alzheimer's patient with Alzheimer's disease. Where in many of these works we observed that a compound named call it Philippine is used as a marker of cholesterol cell content. Philippine is a polyene macrolide classically used in the diagnosis of Niemann-Pick disease. This reagent binds to cellular cholesterol, producing a fluorescence that we can measure by flow cytometry. We also found previous studies that directly assess the cholesterol content in peripheral blood cells of patients with Alzheimer's disease. In this first work, Pani et al. Found accumulation of neutral lipid in these cells, in these peripheral cells in patients with Alzheimer's disease compared to controls. Another study published by Castello et al. In 2014, with a very small number of participants, directly observed an increase in Philippine fluorescence of peripheral blood mononuclear cells from Alzheimer's disease patients compared to controls. On the other hand, the profile of monocyte subpopulation has been widely related to various neurodegenerative disease in previous studies. In this review from the last year, the changes in monocyte subpopulation and the role that this may have in different neurodegenerative disease are analyzed. In humans, three large subpopulations of monocytes are described. A first group, the most numerous of classic monocytes, pro-inflammatory monocytes determined by CD14 positive marker on surface and directly related to phagocytosis and the immune response, which specifically in Alzheimer's disease have been postulated to have a beneficial function on phagocyting beta amyloid peptide oligomers. On the other hand, we have two other subpopulations, an intermediate one, also enriched in CD14 markers, and a non-classical one related to antigen presentation and immune surveillance, which has CD16 markers. Well, in Alzheimer's disease, we observe how these subpopulations are involved in neuroinflammation and in innate immune response in such a way that both classic CD14 monocytes could differentiate into macrophages and intervene in the active phagocytosis of amyloid peptide in senile plaque, and as well as CD16 monocyte non-classical, here indicate LY60 height, could be involved in the phagocytosis of amyloid peptide in the perivascular space. Well, with this background, our primary objective is to determine the cholesterol content in peripheral blood mononuclear cells by measuring their Philippine fluorescence in three groups, a control sample and a group of patients with biologically definite Alzheimer's disease with biomarkers in CSF, including prodromal and dementia phase. We also set out to analyze the percentage and content of cholesterol in different subpopulations of peripheral blood mononuclear cells, as well as to assess the influence of the ApoE genotype on the other objectives. Well, we began recruitment in 2018, including patients with cognitive impairment who underwent lumbar puncture for clinical indication. Diagnostic groups were established based on the biomarker profile according to the biological criteria established by the International Working Group in 2018, based on the ATN classification. Cognitively healthy controls were selected from relatives or informants who came with the patients to hospital. Controls provided only blood samples, but not cerebrospinal fluid. We had a lot of problems to continue recruitment after the start of COVID-19 pandemic in March 2020, so most patients are included earlier. Blood samples were extracted the same day as the cerebrospinal fluid and were processed in the first 24 hours to isolate the mononuclear cells by means of centrifugation and the addition of fecal and PBS in different steps. To achieve cell viability, RPMI and supplemented fetal serum were added to the pellet and frozen at 70 degrees under zero. To measure Philippine fluorescence, cells were towed and fixed in paraformaldehyde for incubation with Philippine. Fluorescence was measured by flow cytometry, and the different subpopulations were determined using surface marker CD4, CD8, CD14, and CD16. Well, we managed to recruit a total of 99 participants with a lot of asymmetry between groups in terms of sample size. One of the reason is the difficulties and the troubles caused by pandemic of COVID-19. Alzheimer's disease being the most numerous group, we did not observe a significant difference in demographic variables as age or sex, or in the percentage of APOE carriers. When we also did not observe significant difference when we analyze in the global form Philippine fluorescence globally, comparing peripheral blood mononuclear cells from the control group with the Alzheimer's disease group. However, if we analyze these results by subpopulation, yes, we can observe a significant decrease in cholesterol content selectively in the subpopulation of classical CD14 positive monocyte that, as you remember, is the pro-inflammatory profile of monocytes. Well, to confirm our results and given the small number of controls, we planned to perform a similar analysis on a historical collection of blood samples from a retrospective cohort of the Peremata University Hospital at the Rovira i Virgili University. In this cohort, subjects were classified into 3 groups: Alzheimer's disease, according to the NINDS-ARDA criteria, clinical criteria, mild cognitive impairment based on Peterson's criteria, and cognitively healthy controls. Blood samples are available, and we could perform similar similar laboratory methods in this sample. Where in this cohort, the sample size was significantly larger with fewer asymmetries between the groups, although the groups with mild cognitive impairment and Alzheimer's disease were still much larger than controls. No significant difference were observed in the demographic variables, although there were a percentage of APOE carriers significantly higher in the groups with mild cognitive impairment and Alzheimer's disease. Well, if we analyze the profile of peripheral blood mononuclear cell subpopulation, we observed a significant increase in the percentage of CD4 and CD16 cells in patients with mild cognitive impairment and Alzheimer's disease. Also, the CD16 cell subpopulation was the smallest in all the groups. We did not observe significant difference in other subpopulations as CD8 and CD4. We can see that the increase on percentage of this subpopulation are present too in mild cognitive, also in mild cognitive impairment phases. Regarding Philippine fluorescence, in this sample, we observed a significant decrease in all subpopulation analyzed. This decrease is from control to Alzheimer's disease patient and is present also in mild cognitive impairment. This decrease of Philippine fluorescence could be translated into a decrease in cholesterol content of all cells, since CD16, CD14, CD4, and CD8 positive leucocytes. Well, however, these differences are not significant when we separate the sample based on ApoE carrier status. In this way, ApoE carriers, particularly in controls, do not show significant difference in cholesterol content in all subpopulation, maintaining this difference only in non carriers. Where our study have several limitations, the most important being the sample size of the first study with large asymmetries between the groups. On the other hand, there is no determination of biomarkers in cerebrospinal fluids in the retrospective cohort of hospital Peremata, and the percentage of ApoE carriers in the groups may have induced a bias in some of the results. Despite this, the results of the analysis of the two samples could be summarized in the observation of changes in the cholesterol content of PBMC in patients with Alzheimer's disease that selectively and predominantly affects certain subpopulations, such as pro-inflammatory CD14 monocytes and T helper CD4 positive lymphocytes. On the other hand, the increase in the percentage of the CD4 positive subpopulation in patients with Alzheimer's disease is significant. Furthermore, we also observed that the ApoE genotype could act as a modulator of the changes described above. If we review what has been published in other previous studies regarding the main conclusions drawn, we see that with respect to monocytes, a decrease in the percentage of inflammatory population or pro-inflammatory subpopulation is observed in the phases of dementia in another studies. Although the activation of monocytes seems to be greater in the phases of mild cognitive impairment, which could be one of the factors influencing the progression to dementia in this subject. A decrease in monocyte migration is also observed in all cognitive impairment groups in this study. In this study, they also observed an increase in the percentage of CD16 positive subpopulation similar to that observed in our study. In addition to quantitatively number of subpopulation, a decrease in the phagocytic function of monocytes is also observed with age and in patients with Alzheimer's disease. As we can see in this study, this decline in function of these monocytes affect all of the subpopulation, both classical and CD16 subpopulation. Well, therefore, the question that we could ask ourselves with the results of our study is whether this decrease in cellular cholesterol content could be the cause of the decrease in phagocytic function in CD14 cells. Although there are no studies specifically designed to answer this question, some previous work indicates that the function of macrophages may be modulated and changed depending on the lipid content of the cell environment, having observed this in these studies with cell models. The other question we can ask ourselves is whether the increase in the percentage of CD4 positive cells observed in our study could be related to some features of Alzheimer's disease. In this sense, there are many previous studies that indicate that CD4 T lymphocytes, which belong to the helper T cell groups, could be related to various effects on the disease. T helper cells are responsible for activating the production of antibodies. In studies in which actions are carried out with the aim of reducing the activity of these cells, positive effects on the disease have been obtained. In fact, as we can see in the graph on the slide, the infiltration of CD4 T cells in the central nervous system would produce the release of pro-inflammatory cytokines and would lead to an increase in beta-amyloid peptide deposit. Finally, and taking into account the absence of findings in ApoE carriers, in our sampling, we could ask ourselves if the ApoE genotype could somehow modulate the changes in the percentage of PBMC or in cholesterol content. In this sense, previous published studies suggest that ApoE could increase the innate immune response in humans, and this mechanism could be involved in Alzheimer's disease. In this study, we can observe changes in the production of cytokines against different stimuli depending on the presence of an ApoE4 alleles. But beyond this finding, the observation made when assessing the extension of lipid wraps in ApoE3 and ApoE4 patient is very striking, observing in this study an increase in these lipid wraps in the groups of carriers of ApoE4. This fact could explain the absence of changes observed with Philippine fluorescence in the group of ApoE carriers in our study. Well, finally, as conclusions, we have to highlight that the cholesterol content of peripheral blood mononuclear cells could be related to the pathogenesis of Alzheimer's disease. On the other hand, neuroinflammation and the innate immune response in patients with Alzheimer's disease could be altered in response to changes in the cholesterol content of peripheral blood cells. This fact, in turn, could be mediated and modulated by the ApoE genotype. More studies are needed to clarify the role of ApoE genotype and its influence on cholesterol content of peripheral blood mononuclear cells and its possible relationship with neurodegeneration mechanism beyond amyloid. Oh, thank you. Thank you very much.
All right. Thank you very much. A nice presentation. So now the paper is open for discussion. As I say earlier, if anyone is interested in making a question, please send a message through the chat option you have on the upper side of your screen, stating your name and affiliation, and I will give you the floor to post the questions directly. In the meantime, let me remind you that the program for the upcoming webinars for the next few months are already available at the CIBERNED website. So if you're interested in looking at the next webinar from now until I think until July, the whole list is available at the website. Remind you that the webinars are held every other week on Thursdays at 3:30 p.m. and are open to anyone which is who is interested. Okay. I haven't received any requests for questions, at least yet. Okay, so while we wait, let me just make a quick question, Ángel. You mentioned that the cohort from the EDPAS, you have, if I understood well, you have looked at the CSF biomarkers, yeah. But that you don't have CSF available for the cohort from Tarragona, actually. So are you planning to use or to measure blood biomarkers in those individuals?
Oh, we could to determine this blood biomarker, but I think that this is a historical cohort of patients, and the clinical criteria is very different than the criteria we use usually now. The principal limitation, the main limitation, is that now we know that in mild cognitive impairment group there were Alzheimer's disease and another neurodegenerative disease, and probably in this historical core, in this group of mild cognitive impairment without CSF and biological biomarkers, we could find another disease different to Alzheimer's disease. No, this is the main limitation of this type or this kind of studies, of retrospective studies. We have a lot of problems with pandemia because we want to increase the number of our cohort with CSF in Alzheimer's disease, in mild cognitive impairment, and we would like to compare with another neurodegenerative disease without amyloid, only with T positive biomarkers, only with tau, such as frontotemporal neurodegeneration and etc. No, because we thought that this mechanism of neurodegeneration could be present in other neurodegenerative diseases, and the function of ApoE4 modulating innate response in immune could be global in other patients. No.
All right. So thank you. Yeah, just another quick question. So, you know, in many cases, the clinical dementia diagnosed as Alzheimer's disease can mix with mostly vascular dementia. So you have any idea whether that distinction between vascular and pure Alzheimer's dementias, so to call, will have different effects or different values for the cholesterol pathway?
Yes, this is a very good question, and this is very different to distinguish in the clinical practice. We will try to compare plasma cholesterol to Philippine fluorescence in cells, and the small sample size did not permit conclude a relationship. In our small sample, there is no difference between such patient with hypercholesterolemia in plasma and the cholesterol or the membrane cholesterol in leukocytes. But the most of epidemiologically studies in cholesterol and Alzheimer's disease have this trouble or this problem because it's very difficult in practical clinical to distinguish between a pure Alzheimer's disease and Alzheimer's disease with vascular disease. No, the CSF biomarker is one approximation, but the part of vascular disease is very difficult to measure with a biomarker.
All right, thanks. Okay, so we still have some time for additional questions, if there are any. I don't see any coming into the chat, but again, if anyone is interested, just send a short message with your name and affiliation, and I will give you the floor. No questions? All right. So if there are no more questions, I would like to close the session, but not before thanking Ángel for his willingness to share with us his work. For everyone to attend this webinar, And I invite you all to come back to the upcoming webinars if you're interested in any of them. So thank you very much, Ángel. Thank you, everyone. And have you all a good afternoon. So I'll see you in a couple of weeks. Bye-bye.
Good afternoon.